So good evening, everybody, or good afternoon, or good morning, depending from which part of the world you are joining us tonight for our 9th Migraine Masterclass, which is organized in collaboration with the Association of Migraine Disorders and sponsored by Pfizer. Before presenting our moderator for today, I would like to say few words about World Pharmacist Day, as today mark the World Pharmacist Day, and I would like to take the opportunity to celebrate and acknowledge the role of pharmacists as an essential team player in the healthcare. So whether you are a community pharmacist, a hospital pharmacist, a clinical role, or drug development, or in the academia, or any other pharmaceutical field, or whether you are a pharmacy student, today is about you. You definitely make someone's life better every day, and you should be proud to be a pharmacist. So let me also take the opportunity to thank our 4 pharmacists who are the soldier behind the success of our IVPN NeuroPsychiatry webinar, Dr. Hussam As-Salamat, Dr. Ghida Ismail, Dr. Noor Nubani, and Dr. Anfal Al-Ani, who are part of the IVPN NeuroPsychiatry organizing team. And to all pharmacists joining us tonight, I would like to say Happy World Pharmacist Day. Having said that, I would like to introduce our leader and moderator of today's webinar, Dr. Naya Kutekar. So Dr. Kutekar is a senior consultant neurologist at Kuwait Hospital Sharjah, Emirates Health Services. He is also an associate adjunct professor of neurology at University of Sharjah. Dr. Kutekar is the founding member of Emirates Neurology Society. He is a fellow of the Royal College of Physicians and a fellow of the American Academy of Neurology. He is also member of the Association of Migraine Disorder. Dr. Nayar participated and chaired in many local and international conferences with interest in headache, multiple sclerosis, neuromuscular, and tropical neurology. It's always a pleasure to have you, Dr. Kutekar, with us. Please proceed by introducing our first speaker. Dr. Kutekar? Dr. Kutekar, are you with us? It seems you got disconnected, Dr. Nayak.
Yeah, you can hear me now?
Yes, now we can hear you.
Okay, thank you, Maya, for the very nice introduction. And also congratulations on the World Pharmacy Day. I welcome you all. Especially, I want to thank Pfizer for their invitation to moderate, given me the chance to moderate this session, and also the Association of Migraine Disorders, I'm also a member of this interesting institution, and I have learned a lot from them. So without wasting more time, I want to introduce Andrea Murphy. She is a board-certified nurse practitioner with extensive experience in headache diagnosis and practicing since 2009. She helped to set up the first headache medicine program in Hartford, Connecticut in 2015. She has special interest in migraine in pregnancy, chronic migraine disorders, and menstrual migraine. She offers individual patient-centered care for patients and to have a holistic approach to patients to treat their headache and migraine. I think we have a very interesting talk. She'll be talking on treatment of migraine during pregnancy and breastfeeding. What are the options and challenges? Eagerly, we all are waiting for this interesting and challenging talk. So can I introduce Andrea Murphy to start her talk, please? Thank you.
Thank you, Dr. Kotakar, for the warm introduction. Can everyone hear me okay?
Yeah, I can, Andrea.
Yes,
Excellent.
yes.
Great. It's lovely to be here with everyone, whether it's during the day or in the evening. What a way to be able to come together and learn a little bit more about migraine, something that I am passionate about and advocating, particularly in this demographic where maybe historically women were told there really aren't many options when you're pregnant. So thank you for having me today. And congratulations again to the pharmacists on the call as well to celebrate them. All right, let me share my screen. Let me see here. Can everyone see my screen okay?
Not yet.
Not yet, Andrea.
How about now?
We can't see it yet.
Maybe just try to unshare and share again.
It's okay now, Andrea. We can see.
Excellent. Okay, I'm going to get started then. So my presentation is on the treatment of migraine during pregnancy and breastfeeding. What are the options and challenges? Here are my disclosures. And today we will be talking specifically about the impact of migraine on this population of women during pregnancy and breastfeeding. I also wanted to make sure we discuss what there may be some secondary headaches to consider when a woman comes with an atypical presentation of headache while pregnant or breastfeeding. And then probably most of interest is what are the treatment options that are available? So first, talking about more of the epidemiology, we know pregnancy is common. We don't have to share that with you today. However, migraine is equally common. So worldwide, migraine is the second leading cause of years lived with disability. And it's disproportionate where it affects men less so compared to women. So after adolescence, women are impacted more. And about 1 in 5 women will experience migraine. Also, the most common age for women to be impacted by migraine are during their reproductive years. So between the ages of 15 to 44 years old, which is also the demographic we're talking about today. And not of surprise, a majority of women, up to 80% of women with migraine will experience migraine during pregnancy. I have listed here the criteria for diagnosing migraine, and this comes from the International Classification of Headache Disorders. And so migraine is a diagnosis, a headache of a longer duration headache, so at least 4 hours, however, it can go on if untreated or unsuccessfully treated for days, even greater than 72 hours. And so this headache, at least 2 of the following 4 characteristics. So it can be unilateral, pulsating in quality, tends to be debilitating, so moderate or severe pain intensity, aggravated by or caused causing avoidance of routine physical activity. So returning really impacting a woman's quality of life. And D listed here during headache, at least one of the following. So someone with headache may also report nausea and or vomiting, or sensitivity to light or sound, photophobia and phonophobia. So this is migraine without aura, which is more common. However, someone may also have migraine with aura. In the literature, about 20 to 25% of migraine sufferers may also have migraine with aura. So it fulfills similar category with migraine. However, they may also experience one or more of the following reversible, emphasis being on reversible aura symptoms. Most common is vision, scotomas, funny spots, things like that can last anywhere from 5 to 60 minutes. Sensory or speech language can also occur. 2 or more symptoms can also happen at the same time. And at least one aura symptom is one-sided. Typically it can be on the side where someone is experiencing the headache. And again, I like to emphasize this is fully reversible and typically lasts less than an hour. Hormonal changes that affect women with migraine are common. It's not surprising to hear a woman may describe even their first migraine started at the start of when their periods began. And in fact, menstrual migraine, we know, even if a woman is having migraines at other times of the month during menstruation, those headaches can be more debilitating. Oftentimes, those are when they're missing time from work or school or important life events. Here you can see listed on my slide, there are other hormonal milestones. Particularly, we're going to talk about pregnancy and breastfeeding, but even any type of birth control could either be a triggering factor, or particularly those that are triphasic in nature, or some oral contraceptives can actually be used as a treatment for menstrual migraine. Particularly those that are monotherapy are more likely to help keep hormones in homeostasis or in balance. Then there's also perimenopause, menopause, and the use of hormonal therapies. So particularly hormonal changes during pregnancy, what is happening usually when a woman becomes pregnant, estrogen levels are rising. And then there's lack of estrogen cycling or ovulation. And so when that happens, generally women feel better. So 2/3 of women experience improvement, particularly in the second and third trimester, because that's when estrogen has risen much higher. However, some women do not, the point of our talk today. And unfortunately, women who describe migraine with aura are less likely to improve their migraines during pregnancy. There have even been reports of migraine or migraine with aura being the first time during pregnancy. Again, that hormonal milestone. What about postpartum? So we talked a little bit about pregnancy, what's happening hormonally. So the opposite happens postpartum. So a woman, say if they felt better during pregnancy, particularly as their pregnancy progressed, about 1 out of 2 women, 50%, report their migraines soon return postpartum, even within a few days of delivering their baby. And what's happening in the body is estrogen levels are falling. And there's also changes in the endothelial lining. Not to mention, more commonly reported migraine triggers are also present. For example, environmental factors, right? So the stress of having a new baby, lack of sleep, dehydration. These triggers can compound migraine postpartum. I listed here, there's a statistic where about 1/3 of women will have migraine recurrence the first week and 50% within the first month. However, there can be some hormonal reasons why breastfeeding can be protective, particularly related to oxytocin release, maybe an area of opportunity still for the future. And then I wanted to make note that there can be secondary headaches, if you're a practitioner listening on this call, to be aware of. So anyone who is having more atypical headaches really want to consider things like RCVS, which is reversible cerebral vasoconstriction syndrome, or cerebral venous thrombosis, even preeclampsia, especially within those first couple months postpartum. These would be headaches with increased morbidity and mortality. So most women who are pregnant and have migraine, there doesn't need to be any further evaluation, okay? However, this mnemonic here is to screen for any red flags, and pregnancy is on the list. So if someone, I like to give examples of a new or unexplained abnormal finding on their neurological exam, atypical headache features, headaches that don't fulfill migraine criteria that we just went over through the ICHD, sudden severe headache, worst headache of your life, significant changes in the characteristics, or they're having other symptoms. Examples might be fever, stiff neck, elevated eye pressure. This would be a reason to further evaluate and make sure we have the correct diagnosis at hand, particularly ruling out more worrisome secondary causes for headache. So this is a single center retrospective review. It's a few years old now by some of my colleagues in New York, but the take home is secondary headaches do happen during pregnancy. About a third of pregnant women who came in for headache at their center did have a secondary headache, and here are some of the examples. So vascular etiologies may be things like preeclampsia, eclampsia, venous thrombosis, stroke, any type of bleed or hemorrhage, press, RCVS, as well as arterial dissection. And then there's some non-vascular causes for secondary headaches listed like here: pituitary apoplexy, intracranial hypertension, also known as pseudotumor, and then tumor including microadenoma. So about 30% of women came in with secondary headaches. Okay, so I like to repeat, most women who are pregnant do not need a headache evaluation further if this is their typical migraine pattern. However, if there were any of the red flags we talked about, an MRI of the brain tends to be the gold standard, is preferred imaging study during pregnancy. And that's because even though the risk of radiation is low, there is still radiation with a CT of the head. Gadolinium during an MRI should not be administered just because we know that actually causes fetal toxicity. But with any imaging study, we really want to mitigate the risk versus benefit to the mother and the fetus when deciding which scan to order. Challenges to treatment. So ideal scenario is preconception counseling when possible. Certainly, having that dialogue, that open dialogue, even months, even years with your patient before maybe family planning is being considered. But ideal versus reality, right? So we know up to 50% of pregnancies are unplanned. So that doesn't necessarily always happen. Also, the medication management during pregnancy and breastfeeding is understudied. Just because it's understudied doesn't mean that we don't treat migraine. So particularly, what are the concerns about known treatment? So safety and teratogenicity of medications. Some we do know about and some are unknown, particularly looking more at long-term fetal neurobehavioral outcomes. And then almost on pregnant women, will you ever see a double-blind randomized controlled trial? That's the gold standard, but that's not reality in this population. And then more commonly, what is reality is seeing safety data that comes from retrospective case studies, particularly also registry studies or any type of bigger database studies, which we will review some of those today. What are the adverse effects if we don't treat migraine during pregnancy? So here's a couple of statistics for you, but we know migraine attacks, especially those associated with vomiting, can lead to dehydration and electrolyte imbalances, requiring hospitalization during pregnancy. There is also, with having a diagnosis of migraine, there is an increased risk, anywhere from 1.5 to 3-fold increased risk of developing preeclampsia, as well as other hypertensive disorders in pregnancy. In terms of neonatal outcomes, there have been reported lower birth weight, also preterm birth as well, and longer NICU stays in babies, particularly concerns with respiratory distress syndrome and febrile seizures. There also treatment of migraine during this population may reduce migraine-related presenteeism and absenteeism, particularly important also if you're considering pregnancy-related discrimination in the workforce. Poor management has also been associated with physical and mental health conditions, both ante and postpartum. These are all the reasons to treat migraine during pregnancy. So the management of migraine during pregnancy in one slide. So looking first at the top left are lifestyle considerations. So really optimizing their routine. So looking at sleep patterns, hydration, diet, exercise. How are we coping with stress? Incorporating behavioral treatments. And here's a few, there are more. Things like biofeedback or cognitive behavioral therapy, which usually can be done by either a social worker or a psychologist in this field. Meditation, relaxation practices. And so, as you can see, most of these are non-medicinal lifestyle considerations, but so important to have discussions about with your patient, and not even, if possible, that ideal scenario when we're talking about preconception counseling, months in advance of family planning. Listed here is addressing risk factors for chronification. So we know that there can be a progression of migraine as a neurological disorder, and the more common risk factors are sleep disturbances such as insomnia, comorbid mental health conditions like anxiety, depression, previous trauma, obesity. So looking at these risk factors more from a holistic perspective and really prioritizing, the patient at hand can be very, very helpful. Then when we move to the top right of this screen, so other non-pharmacological treatments that can be helpful, acupuncture, but particularly by a provider who is accustomed and familiar with treating pregnant women. Other physical treatments that are gentle are things like cranial sacral therapy, osteopathic manipulation, massage, and there are some devices we will talk about in the slides to come. The bottom of my slide here is talking more specific about prescription treatments, okay, whether over the counter or prescription. So abortives, so these would be medications you would take as needed for a headache. First line is acetaminophen. It's been that way for a long time, but we're going to go beyond that during this talk and talk about other medications, particularly antiemetics can be helpful, like meclopramide. Also antihistamines like diphenhydramine. And lidocaine we'll talk a little bit more about. Second line treatments, triptans are more migraine specific. And then there's some other antiemetics listed as well, promethazine, prochlorperazine, and some steroids listed here. Prevention. So prevention means a medication typically that you would take every day to help with the overall frequency and debility associated with a woman's headaches, okay? It depends on the criteria you're using, but typically it's based on frequency. So if someone is having greater than 4 headache days per month. However, the conversation I have is really about their quality of life. And there's different scores that can be used. Most common in my practice, we use the MIDAS score, which is a disability score. But at the end of the day, if somebody is missing work, really having a tough time during their pregnancy, you really would like to be considering preventive strategies, in addition to making sure we're focusing on the top of this screen, which is the lifestyle and non-pharmacological treatments. First line is propranolol. We'll talk a little bit more about magnesium as well, and amitriptyline. So before talking about medications, here's a caution. So really want to stay from any medications that we already know is teratogenic, particularly any that can impact the uterus or cause vasoconstriction. Example, in the migraine world are things like ergotamine. So that would be things like dihydroergotamine or DHE. NSAIDs are, there's a lot of data about NSAIDs, and really it comes down to the gestational age. So first trimester, I would avoid NSAIDs, any non-steroidal anti-inflammatory drugs. Particularly there's a concern for malformations as well as miscarriage. And then after 30 weeks gestation, so we're talking more in the third trimester, I would also avoid NSAIDs. Particularly the concern is exposure to NSAIDs after 30 weeks, increased risk of premature closure of the fetal ductus arteriosus. There have also been concerns about lower amniotic fluid at that time impacting birth outcomes. Other caution is in any drugs of abuse, particularly Opioids. Opioids is not ideal for the management of headache in general. Particularly, we know that opioids increase the risk of medication overuse and just complicate treating migraine. Benzodiazepines equally are not very effective treatments for migraine. And what, at least here in the States, butalbital containing products are actually fairly common, especially, comfort level for women's health providers. My team and I were involved with studying how OBGYNs or women's health providers feel in terms of their comfort level with treating migraine during pregnancy. And this medication is often used. However, there is some concern. So particularly there's congenital heart defects. There could also be withdrawal from this medication postpartum, both for the fetus and the mother as well. And then there's the unknown, where we don't know the risks of certain medications, some of the newer medications, for example, although we're starting to learn as data comes available. So looking at acute medications, so these are medications you would use as needed for migraine. They are most effective if used early into a migraine attack, particularly within those first 30 to 60 minutes of migraine, which really should be enforced during the counseling. But triptans are migraine-specific treatments. So they've actually been around for quite some time, over 20 years now. Sumatriptan is probably the triptan we have the most information about in terms of safety data with pregnancy, but there are a total of 7 triptans listed here. Imitrex is sumatriptan, Maxalt rizatriptan, Relpax is elatriptan, Zomig is zomatriptan, Axert is almatriptan, Emerge is naratriptan, and there's also Frova or frovatriptan. So these are migraine-specific treatments. They particularly work on 5-HT1B/D agonists on serotonin receptors. Particularly the way they work on migraine is they're inhibiting the release of inflammatory peptides, also constricting vessels dilated by CGRP, which is exciting. A lot of newer medications also work on CGRP. I like to enforce, because of the vasoconstriction, this is really big contraindicated treatments for anyone who has a pre-existing cardiac history, particularly ischemic disease we're talking about, or any poorly controlled hypertension, whether pre or during pregnancy, coronary vasospasm. There are also many different formulations that triptans come in. Listed here, you'll see tablets versus dissolvable nasal sprays, subcutaneous injection. So it depends on patient preference, but also their migraine profile, if we need a medication to work faster or not. Here's some information about triptans and their safety. We actually do have a fair amount of larger studies. So in 2015, there's a meta-analysis that looked over 4,000 infants who were, their mothers were using triptans in utero. So there actually was no increase in major congenital malformations, premature birth, or spontaneous abortions among triptan users compared to women who weren't on triptans. Another study I'd like to include here looked at 432 women, again, using triptans, and really there was no adverse outcomes mentioned. And then what about long-term? We were always concerned about behavior, behavioral outcomes. So there is a Norwegian study, a cohort study, looking over 5 years' time after in utero exposure to triptans. It looks like in utero, they scored, for some reason, they were higher in terms of sociability. We don't really know what that means, but there was no negative developmental concerns long-term, at least within the 5-year time frame. So in my own personal practice, I tell patients, who have migraine, there's different levels, but if possible, we know that during organogenesis is most critical during the first trimesters, if possible, to try to use medications very sparingly. But if needed, I tend to prescribe sumatriptan. We have the most evidence in terms of safety with sumatriptan. This is not done alone. I am very fortunate to have a multimodal team where I work very closely with their OBGYN. Also, I have some maternal fetal medicine specialists who go at quite detail of all of the known literature that is available with medications used to treat migraine. Typically with breastfeeding, I tend to use elatriptan or Relpax, only because of the pharmacokinetics. We know that L-triptan is highly protein bound, so the likelihood of it being in breast milk is very, very low. All right, so now talking about preventive. So these would be medications used for reducing the overall frequency and intensity of headaches and reducing headache-associated disability. The reason propranolol, also metoprolol, are considered first line is because we have the most data available. And there is still some concerns for fetal growth restrictions with this medication, but most of the safety data actually comes from the women's health field, particularly using beta blockers during the treatment of preeclampsia. And then, so that's preferred. Second line, when we look at the tricyclic antidepressants, that's amitriptyline or nortriptyline listed on this list. There's also a fair amount, lots of study data on these medications. I do like to point out there is a risk of neonatal abstinence syndrome. So something for the OB team to be aware of that, you know, if decide from a risk versus benefit standpoint, a mother stays on this medication. Vitamins. So CoQ10, typically the dosing is 300 milligrams daily. Magnesium is listed on third line. However, I use it very frequently. The dosing is anywhere, at least PO, from 400 to 600 milligrams of magnesium. And then also vitamin B2 is listed here, which is riboflavin. That's 400 milligrams a day, typically dosed. And so I feel very comfortable offering vitamins to my patients. I will say, so magnesium, there have been reports, particularly in high dose IV, concerns with magnesium competing with calcium and concerns for fetal bone development. So that would be something to just caution, but that's not typically how it's being used for migraine for prevention. And this is several days, and that data actually came from the treatment of preeclampsia. In terms of some other medications on this slide, so gabapentin and pregabalin. Low risk of malformations. There are some reports of higher risk of preterm labor, low birth weight, although there are limited randomized controlled trials with these medications. All right, and then venlafaxine is listed here as third line. Inconsistent results across studies. There is some concern for increased risk of preterm birth, and this would be the case whether a woman was pregnant or not. There is an increased risk of hypertension, so it would need to be something to be monitored if chosen during pregnancy. Medications avoid when possible. Some of these medications, so the CGRP monoclonal antibodies, we're going to talk a little bit more about, but the ideal would be to stop 4 to 5 half-lives before conception. And that's because they have a very long half-life, especially with the injectable treatment. Excuse me. The concern may be there may be an increased risk of preeclampsia. Again, none of this has been proven, but CGRP we know is a potent vasodilator, and so that might be necessary to support a woman during pregnancy. And the lisinopril is listed to avoid. So pyramate, the concern, while it's still low, is there is a risk of cleft palate and lip within the first trimester. So generally I would avoid. And then feverfew can actually induce contractions, so concern for miscarriage. And we know valproic acid as well as methadone is teratogenic during pregnancy, so avoid altogether. What about procedures? So in general, I don't know in terms, most of these procedures can be done even in a primary care internal medicine office. So we're talking about using a medication called lidocaine. I actually even use lidocaine as an abortive. So particularly it can be compounded and used as a nasal spray as needed for women with migraine. We know there's lots of safety data with lidocaine during pregnancy. So in this slide, procedures that can be done are nerve blocks and trigger point injections. The most common tend to be at the base of the head or the greater and lesser occipital nerves. This can also be helpful for neck discomfort too, but trigger points are any areas of tightness or muscle tension, and not only can those areas be injected, but they can cause referred pain, and usually that's in the head. So this procedure can be done on a serial fashion to also prevent migraine. So serial meaning every few weeks. It really depends on the woman and how long the effects last. Sometimes also we just really need to get them out of that first trimester when they're more likely to be debilitated, get them to where those estrogen levels plateau. Okay. Onabotulinum toxin A. So this is not approved for during pregnancy. However, understanding the mechanics of this treatment. So this is Botox. It is here. This is a protocol used particularly for the prevention of chronic migraine, but it's a large protein and unlikely to cross the placenta. There is also, knowing, this is botulism. There has been some studies talking about, or cases, reports of women who have had food poisoning. There is concerns for preterm labor. However, this treatment has been out for many years, not just for the prevention of migraine, but also for other indications. And so there is some registry data, particularly listed here. There's over 232 eligible pregnancies that were exposed, mothers were exposed to onabotulinum toxin A, either before being pregnant or during pregnancy within those 3 months. And it looks like for the most part, it's generally safe. So no fetal malformations or any increased risk of miscarriage, similar to the general population. Oops, excuse me, I went too fast. Oh, all right. And then what about long-term safety data? So 45 patients receiving particularly Preempt is used for the prevention of migraine. And these children were studied over 9 years, and it doesn't look like there's been any outcomes that are concerning. So in my practice, it really comes down to how debilitated the mother is and looking at those adverse maternal outcomes and weighing the risk versus benefit here. Usually it's also done in combination with some of my maternal fetal medicine colleagues to make sure we're all on board who would be a candidate for this treatment. So there are some newer therapies out there. So calcitonin gene-related peptide therapies. It's still fairly new, but there have been some safety reports. So in 2019, the World Health Organization put almost 100 safety reports, particularly looking at the injectable monoclonal antibodies. And as of right now, it doesn't look like there's any major safety concerns. Again, that's a very small number and needs to be more long-term safety data, but it's promising, that these that there is registry data out there. Also looking at the smaller molecule CGRP rimegepant, looked at with 12 women postpartum, and they were using this treatment as abortive with breastfeeding. And the levels were very, very small in the breast milk. So felt pretty comfortable, and there was no safety concerns at that point. Still, take home, need more information. And the way to get that is from case study reports and registry data. Okay, and these are the non-medication devices that are approved for migraine. I like to point out that they are not approved, none of them have been studied in pregnancy or breastfeeding. On the left is the Cephaly device. This is an external trigeminal nerve stimulator. Right to this, to the right of that is the single pulse transcranial magnetic stimulator. And the middle here is the gamma core device. It's a vagal nerve stimulator. And then Relivion, it's almost similar but to the external trigeminal nerve stimulation, but it also combines the occipital nerve as well. And then the Neurivio device is an armband, and it's a remote electrical neuromodulator. So there's some registry data on these devices as well. I'm including here the Neurivio device. So there was a retrospective controlled survey study included 59 pregnant women using this device, and it looks like relatively safe, but again, we need some more information. In my practice, general consensus is it is safe to use these treatments, but as long as there's no contraindication to the device itself. For example, more common contraindications to neuromodulators are uncontrolled seizures, implantable cardiac devices, etc. Excuse me. All right, so to wrap up, migraine is common in women during their reproductive years. The majority of women will experience improvement in migraine, so that's exciting. But it's still important to treat these women, even if they continue to have migraine. If anything, I would advocate that this is essential to their prenatal care. Early open dialogue is key. If possible, preconception counseling when with looking at more optimizing the lifestyle and non-pharmacological treatments. Although medication safety is not well studied in this population, there is still evidence to support the use of both acute and preventive treatments when needed. And then you don't want to forget to screen for any red flags during pregnancy and postpartum, particularly not missing any headaches that are associated with increased morbidity and mortality requiring emergent evaluation and treatment. And also migraine treatment for the most part is compatible with breastfeeding. There are safety databases publicly available to help in the decision-making, and I will share those in the next slide. And then there's new emerging safety data on the treatment of migraine during pregnancy and breastfeeding, but these usually can be found through specialty organizations, experts, and rely on your national registries as well. I have included the registry here in the States, but of course, each country has their own. And that just shows you what's up to date, and the way these registries work is you have to enter that data in. So if you have a patient who is pregnant or, things happen, we want to monitor and see, see what those outcomes may be. So on this slide here are resources, particularly the first three are more resources for medications and reviewing the safety data, particularly with breastfeeding. And then also is registry data. And the last two resources, curable and expectable, are more addressing the risk factors that contribute to progression of migraine and making sure they feel well supported more from the lifestyle standpoint. And that's all I have. Thank you.
Thank you, Andrea, for a very elaborate and accurate talk on many aspects, which are very interesting. I'm sure we'll have lots of questions at the question and answer session. Our next speaker is Mona Thackeray. We've been working, I think, together for more than 20 years.
Just Dr. Nayak, apology for interrupting you. Can we take the question for Andrea after her session because she has to leave, please? So can we take the question for Andrea? Yes, no. Let's take the question for Andrea now as she has commitment and she has to leave after the session.
Sure, okay.
Please, thank you.
Yeah, okay. So we have congratulations. How do we give lignocaine and at which trimester? I think lignocaine is, you are thinking of talking of occipital block, the nerve blocks. Are you giving, Andrea, in your hospital, you are giving nerve blocks for pregnant patients?
Yes, so lidocaine can actually also be used as a nasal spray. So this would be more over the counter. You would work with pharmacies that have the capacity to compound lidocaine. So typically it's 4% compounded lidocaine every 4 to 6 hours as needed as a nasal spray, can be used abortively. And this is during pregnancy. It doesn't matter the trimester. So throughout their whole pregnancy and during breastfeeding. And then similar lidocaine done as a procedure. It's usually 1 to 2% lidocaine done just under this, just under trigger points would be in the muscle, but particular areas that are more common are the greater occipital area. Sometimes in terms of nerve blocks, it'd be like supraorbital, supratrochlear, just under the skin and those areas. Also auriculotemporal. Muscles in the neck and shoulders can be done as well, like trapezius and cervical paraspinal muscles. And in terms of coverage, usually at our center, this is a fairly benign procedure. They come in every few weeks for this, and it can be done throughout their pregnancy and, breastfeeding as well.
Thank you very much. The next question is from Nariman. He wants to know triptans and amitriptyline, at which trimester you use them for migraine?
I'm sorry, you broke up there. What, it was amitriptyline?
No, amitriptyline,
yes.
triptans,
Oh,
sumatriptan.
Sumatriptan. So sumatriptan, I shared with you what safety data we have available, which is actually fairly robust, especially for sumatriptan. So it really depends on the patient. And again, working closely with their OBGYN. I have some OBGYNs that still just don't feel comfortable with the triptan. So that's one thing. But if we're working together, we feel comfortable, really, as long as I use it even in the first trimester. We just try to use it sparingly. It's, again, there's not anything to say that for certain that would be a safety contraindication. I just thinking at things over in terms of understanding that most of the development of the fetus is in the first trimester. That's why we use it sparingly there. But safety wise, it's fairly, the outcomes are very good.
There's a lot of data on sumatriptan, both the subcutaneous and the nasal spray or oral. And we use a lot of sumatriptan and zometriptan during pregnancy. I'm sure you can use the others, but the data we have is mostly for sumatriptan.
So some of the safety that I included was a meta-analysis of all the triptans. It wasn't just sumatriptan. But I agree with you that we have the most information about sumatriptan solely because it's been out the longest, probably.
Sure. And it's available both as a spray, tablet, and injection. That's the other advantage. Okay, so we have another question from an anonymous attendee. When should patients stop Botox, CGRP, monoclonal antibodies, and GPANs? I think it goes beyond the pregnancy question, but are you able to answer that, or should we leave it for Mona?
I tell them, because of the long half-life of the CGRPs, particularly the monoclonal antibodies that we're talking about, I usually have them stop at 4 to 5 months before. But of course, we want to talk about a transition and then what is going to be used instead for prevention. We don't want to just stop a medication and say like, oh, there you go. We want to make sure we're optimizing some of those other considerations we talked about.
So Malik Qasim is asking about, is there any relationship between prolactin level and migraine? Do you want to take that? Or
sure.
You want me to,
Not specifically just for migraine. We know prolactin and other secondary, more concerning things, right? Prolactinomas and things like that. But really, we know estrogen plays most of the role in terms of from hormone, although we're also finding out progesterone could also be helpful too for women. Or the idea of why during pregnancy headaches can get better is because ovulation is stopped. So that is why it can be really helpful, why oral contraceptives could even be a treatment for menstrual migraine.
Sure.
And postpartum, one more point, postpartum, some women don't get their period right away. And that's where we talk about how breastfeeding can be a little bit protective in that regard. We still have more to learn, but because ovulation is stopped, well, I don't recommend that as a first line contraceptive method. That could play a role in why they're not as susceptible to migraine if they don't have their period.
We will take it as a caution if the prolactin levels are in thousands, like not just hundreds, but because that would mean that the pituitary axis should be investigated. So we have Balkis Walid. Which form of magnesium is best for migraine?
Okay, so there's lots of formulations of magnesium available. Most of the studies are done on magnesium oxide. However, in my practice, I prefer magnesium glycinate. And the reason for that is it tends to be better tolerated, particularly, sometimes magnesium oxide could cause some GI effects, a laxative effect, unless that's what you're looking for. If the woman has constipation, then you go with what makes most sense for that scenario. But magnesium glycinate is also relaxing, so that can be helpful for sleep disturbances too. The dosing still the same, but I'd have them take it in the evening. But if it's more of a constipation picture, magnesium oxide or citrate tend to be more commonly used.
Do you have effervescent magnesium? Do you use that?
Effervescent?
For patients, especially who have nausea, vomiting?
I don't use that.
Magnesium fawar. We call it here in Dubai magnesium fawar. Like, so anyway, the next question is, what is the role of acupuncture? In my practice, it works like magic. This is from Kamis.
Great. I think it's worth trying, like any risk benefit. Of course, I recommend only somebody who treats routinely pregnant women. Here in the States, it can go either way. And I think it really just comes down to how, the practitioner you're seeing who's doing acupuncture. But even knowing that it has that relaxing effect to help, downregulate the hypersensitive nervous system, it's worth a try.
I think, Dr. Nayak, we can take the final question for Andrea. So I will ask you on behalf of Dr. Nayak. So we have a question about topiramate. So you mentioned that topiramate caused the cleft palate in the first trimester. Would you consider using it in the second or third trimester, for example, in patient with migraine with aura, and who might get worse during pregnancy, or you should avoid it all the way during pregnancy?
That's a great question. So in general, I tend to get patients off topiramate. It's part of our preconception counseling. And the reason for that is we do have plenty of other options that can be effective and well tolerated, and we know have better safety outcomes.
And what about
Andrea,
venlafaxine? Sorry, Dr. Nayak. What about venlafaxine in pregnancy?
So I do use that medication. That tends to be used more for refractory cases. It's not a first line treatment. On my slide, it was more of a third line treatment, similar to like amiloxantoxin. And that's in combination with their OBGYN team, making sure they feel comfortable. At our practice, we have like a list of medications that I may consider using, and I share this with their OBGYN team, and they check off what they feel comfortable. Like example be like the triptans, beta blockers, and some of the others we've talked about today.
Thank you, Andrea. I know you have to go. Topiramate about 5-6 years ago was in fashion, and then we had registries coming from Denmark and Scandinavia telling us about this cleft palate and other things. So nowadays, I try to avoid topiramate in any trimester. Thank you very much for your very educative talk. So
You're welcome.
our next speaker is Dr. Mona Thackeray. Mona Thackeray is been in Dubai practicing neurologist for the past 20 years. She has an MBBS and MD degree from Nagpur. She has DNB and Doctorate of Medicine from Bombay Hospital. She also is a fellow of American Academy of Neurology. She worked for 10 years in Rashid Hospital as a specialist neurologist. For the last 7 years, she's a consultant in
I think Dr. Nayak is disconnected probably.
Numbers in United Arab Emirates. So, Mona, the floor is yours. It's always interesting to talk, and she's going to talk today on advanced migraine management with oral CGRP antagonists and the role of rimegepant.
Thank you, Dr. Nayak. It's always a pleasure to be sharing the stage with you, and it's always fun. So after this very, very elegant talk by Dr. Andreas about migraine, pregnancy, and I learned a lot about it as well. And it's always a challenge treating pregnancy and migraine. My role is a little simpler. So it is one simple solution for many migraines, roles of rimegepant. And Dr. Andreas did mention about GPANs and CGRP antagonists. So I'll be talking something about this new molecule. So these are my disclosures. So we've talked about, acute treatment and preventive treatment. So you have to treat migraine in both the ways. So if the patient comes with a headache, you have to treat the headache with acute treatment. And you have to give these patients very effective acute treatments. So acute effective treatments could range from anywhere between a simple paracetamol to acetaminophen, as Dr. Andreas mentioned, to non-steroidal anti-inflammatory, to very specific triptans, or the newer ones, which are the GPANs. Okay. Sometimes we have a situation when these acute treatments don't work, or we have situations where they are not tolerated, or there are some contraindications. And this is where we are in this new era where we have the options of giving GPANs Then we have the preventive medications, which were the traditional preventive medications. And we just heard about beta blockers and topiramate, the anti-epileptic medications. And then we have antihypertensive medications being used as preventive medications. And these also are not very well tolerated and do take their time to kick in. And now we are in this era of CGRP antagonists, and which are the monoclonal antibodies, the injectables, which we just heard. And these have changed the whole scenario of migraines. And they've been there for since 2018, and we've got very good experience with them. But the new kid in the block is the GPANs, which are the oral CGRP receptor antagonists. And we're going to see one of them, which is rimegepant. So rimegepant has been investigated for acute and preventive treatment of migraines in the adults. And we've got number of studies, which you can see, the phase 3 studies starting from 301, 302, 303. And then we had the phase 2, phase 3, 201. And we had the phase 3 preventive study as well, which led to the approval of this molecule, which is rimegepant, or as we know it as Nurtec. So we'll be going into a little more detail into the phase 3 303 and the efficacy and safety and prevention as well, the phase 3 305. So what was this 303 study? So this was to study the efficacy and safety of rimegepant oral dispersible tablet for the acute treatment of migraine. So this was a randomized double-blind placebo-controlled trial. And what they did was they compared it with the placebo. So the inclusion criteria was adults more than 18 years of age with more than one year history of migraines with or without aura. And a total of about 1,466 participants were there. And they were equally divided around 600 odd in both the groups. The mean age was around 40 years. Of course, it was predominantly more females. The BMI was the same. Primary migraines with and without aura was 480 without aura, and with aura about 189. And this was equally matched with the placebo. And both the groups had a disease onset of about 20 years, and the mean duration of untreated attacks was also the same. So pretty equally matched groups. Mean number of moderate to severe attacks was about 4.6 in both the groups. And they had about same number of most bothersome symptoms, which are photophobia, nausea, phonophobia. And the primary endpoint was freedom from pain and freedom from most bothersome symptoms at 2 hours of post taking treatment. And what were the results? You can see that rimegepant, which is in purple, was significantly higher than the placebo, which is in gray. And this was adjusted with the 10% placebo related effect as well. And the freedom from most bothersome symptoms at 2 hours was also statistically significant. When they sub-analyzed it in the secondary endpoints, they found that actually the pain freedom started from 1.5 hours on initially. And you can see that the graph separating at 1.5 in half an hour, and it starts becoming significant at 1.5 hours. So it's not only 2 hours, it starts acting much before. And how long does it last? It lasts up to 48 hours, which is also significant as compared to the placebo. And you can see it in this bar diagram that 60 minutes, 90 minutes, and 120 minutes, there's a significant difference. And of course, there's a significant difference in the 2 to 48 hours as well. So there is a sustained pain relief through 48 hours. And the secondary endpoint was, is the person able to function normally with rimegepant? And you can see that it starts over and from the first hour, there is a difference, and it becomes significant at 2 hours that most patients with rimegepant will be able to function normally after taking the medications. And this effect is sustained over 48 hours. How well tolerated is it? You can see it's almost equal to placebo. It's an excellent tolerability profile. And there was only one person in the study who had a slight elevation of ALT, AST, but we've been using it for more than a year now, and we've not seen any side effects with these. What about the post hoc analysis? And they found that there was a significant difference from placebo from freedom from pain and most bothersome symptoms at 2 hours, regardless of triptan treatment. So what they saw that they subdivided or subanalyzed the whole study into patients who were triptan naive, who had a current triptan use, history of triptan failure of 1 triptan, or history of failure with more than or equal to 2 triptan. Any of these categories, Nurtec actually did much better than the placebo, even if they were triptan failures to 1 or 2, or whether they were on triptans. So let's go through a case for acute treatment. So this is Harry. This is 65 years old, right-handed engineer with a long-standing hypertension, obesity, and recently diagnosed with type 2 diabetes. He has a 40-year history of migraine with aura. And at presentation, he had 3 migraine headache days, which were reduced from 8 from 8 on the preventive medication. And he was on candesartan 8 milligrams, and he used to take rizatriptan 10 milligrams, and he had already previously tried somatriptan. And with rizatriptan, his headaches were relieved, but he used to have frequent recurrences, which required treatment. And of course, he had a lot of cardiovascular risk factors. So this was flagged, and there was a concern that we have to change the triptans. So what do we do now? So, he's not responding to the triptans and of course, NSAIDs as well. So with the multiple risk factors and high recurrence rates of rizatriptan, I switched his acute treatment to rimegepant. It's not a vasoconstrictor, and it would address the cardiovascular precautions with triptan. Rimegepant has an approximate half-life of 11 hours, and the favorable data of 24 and 48 hours actually helps the treatment, and you just need to give 1 tablet and the effect will be there persistent for 48 hours. So it was very effective in this patient, and it treated his acute attacks, and the recurrences were very rare. Let's talk about prevention of migraine with rimegepant. So this was the phase 3 randomized double-blind placebo-controlled trial. And this also included adults more than 18 years of age with more than 1 year history of migraine with or without aura. So what they did was they actually put them on a 4-week observation period of eligible candidates, and they were around 300 plus in both the groups. And the primary endpoint was the change in monthly migraine days from baseline during the weeks 9 to 12. And these were almost equal in the age category, the type of migraines with and without aura, the mean age of onset, the mean duration of migraines. Monthly migraine days were about 10 in each, and history of chronic migraines was almost equal in both the groups. And the primary endpoint, you can see that there was a significant difference in the reduction of the mean monthly migraine days during the week 9 to 12. And this is the placebo, and this is the rimegepant. It reduced more significantly than the placebo. And in the secondary endpoint was significantly more patients taking rimegepant had a more than 50% reduction in the mean number of moderate or severe monthly migraine days during the week 9 to 12 compared to placebo. And you can see that there is a difference between the 2 groups. And this was sustained over a year in the open label extension period. And you can see that this effect continues to be there and actually continues to get better. Safety and tolerability of rimegepant in this study of prevention was also almost equal to the placebo. The liver function test showed low rates of increased enzymes. 4 patients, that is 1% with treated with rimegepant, and 2% who were treated with placebo had a slight elevation of ALT or AST of more than 3. And one patient with rimegepant had an asymptomatic ALT elevation, which was asymptomatic. Let's see a patient who tried preventive. So this is a 30-year-old recently married woman with migraine without aura, returns to the clinic and shares that she's planning on trying to get pregnant in about a year. And she was having migraines 14 days per month. And over the last 6 months, she has started galcanezumab, and she's having 3 days per month of migraine without aura, usually relieved by elytriptan. And breakthrough headaches are usually triggered by stress. So how would we approach this patient? So the considerations were that, galcanezumab, as Dr. mentioned, that the half-life is long, 27 days. So this would approximately take 5 months to be removed from our body. That is 95%. And we still don't have safety, data. So we do advise them to stop these injectables. And so this was discontinued, and we replaced it with treatment which would wash it out more rapidly. And because of her documented response to CGRP, I wanted to give her a short half-life CGRP, which could be tapered off rapidly. And this also was, so other treatment like what Doctor mentioned, that, mindfulness-based stress reduction, neuromodulatory device was also considered in case she got pregnant. So the treatment was that we stopped the galcanezumab, started rimegepant every other day, and I referred her to the health psychologist for CBT, mindfulness-based stress reduction. And we introduced the Syphily device, which is what Doctor showed, the picture of an external trigeminal neural stimulator. And the transition to rimegepant was not associated with any headache exacerbation over the month. And it was used for her acute treatment for any breakthrough headaches as well. And working with her, with our health psychologist and using Syphily device has actually helped control her migraines. So rimegepant is used when necessary. So it is an oral dispersible tablets. So you don't need to take water with it. You can just put it under the tongue and it dissolves. And the maximum dose is only 1 tablet per day. Another dose of rimegepant should be avoided within 48 hours if you are taking concomitantly drugs which are inhibitors of the CYP3A4 enzyme. You don't need any dose adjustments with the elderly and or in mild renal impairment, but you have to be careful with severe renal or severe hepatic involvement. Of course, contraindication is hypersensitivity, and it is not recommended in severe hepatic, end-stage renal disease, and patients using strong inhibitors of CYP3A4 or strong inducers of CYP3A4 medications. So rimegepant for acute migraine and prevention is the only tablet which has been proved in both acute and prevention of migraine, very well tolerated and with no safety issues. And with that, I would like to thank you for your attention.
Thank you, Mona, for a nice overview of medication and this newer medication which we have been started using. I am using it for the last few months. So I think the floor is open for questions, and let me go first. Abdullah Muhammad, World Pharmacy Day, congratulations.
Happy World
When
Pharmacy
do we
Day.
start? Yeah,
Thank you,
I think we
Dr.
should
Mona.
all
Thank you.
congratulate them. Yeah. So when do we start with the prevention? That's from not Abdullah. It's written in Arabic. So could we, Mona, say when do we start with prevention?
So traditionally, we used to always say that, okay, if you have around 4 monthly migraine days, then you start prevention. But even if you have 1 or 2 migraines which are disabling and you have they are not going away, they last for 2 days, 3 days, and the patient is not functional, you do qualify for preventive medications.
I think the main answer is whether the patient is functional. It depends if he's a patient is a CEO or is an administrator, and even if he has a one attack and lasts for 2 days, and his job may be at risk. So I think you should take every patient as a challenge. We have Lena Al Said asking, what about vitamin B12? Do you use vitamin B12 for acute or preventive medicine, Mona?
Not in migraines. There is some role of B6 and riboflavin, but not B12 in migraines. But of course, B12 is a good vitamin. It is a nerve vitamin. Anybody who's having reduced tingling, paresthesias, you have memory issues. So B12 is definitely helpful, but not much role in migraine.
Yeah, one of my mentors, Dr. Anand, he uses lots of riboflavin. It's not easily available here. Is it easily available with you, riboflavin?
No.
In your hospital?
No.
Okay. So I don't see any question. I have one question and a comment. When we use triptans for acute migraine, we have about 30% of the patient, either they are not responders, that means within 2 to 4 hours they have a relapse of the headache. And second thing is that either they develop some chest pain or some dyspnea, so they are not compatible. So you have 30% of the patient with acute migraine qualifying to have another medication. And I have used this medication, Remigipant, in such patients, also specifically for menstrual migraine. I have 3 patients who responded very well. And the menstrual migraine, when they talk to the patient, it's different than their other migraine days headaches. They are having a lot of photophobia, and the symptoms are a little bit different. And there are other, either you have a migraine associated or a migraine, pure migraine with menstruation, and both respond very well to Remigipant. Do you have any comment on that?
So you know what I do? I also use it in menstrual migraine. I use it during that 7 to 10 days of time. So I use it as preventive, and so you give it every other day and cover the migraine pre-menstrual, menstrual, and the little post-menstrual time. So about 10 days of alternative medication works extremely well for these patients.
And Dr. Mona, I have a question, if you allow me. So I know that Andrea discussed that really the efficacy and safety probably of all these anti-CGRP and Rimegepant is not well established in pregnant women. But as you know, these molecules usually they are large molecules that I think theoretically they will not be able to cross the placenta or the breast milk. What do you think?
I mean, scientifically speaking, yes. But medico-legally speaking, we still don't have a clear label. So scientifically speaking, it cannot pass through the placental barrier. So it's very difficult for these big molecules to go through, especially the injectables.
And another question, please, if you allow me. So what is, in your opinion, what's your opinion? Can you comment actually about the result of the challenge MIG trials and how this will change your practice in the treatment of episodic migraine?
Sorry, I didn't know which trial challenge.
The challenge MIG trials.
Oh, I'm not aware of that one.
I didn't hear you, doctor.
I'm not aware of that.
Okay. So let's check if, Dr. Nayak, are you aware of this trial?
I'm not particularly, I don't have the numbers with me, but I've heard of this trial. And there is one more thing which is very important in Remigipant. the other GPANs, oral GPANs can cause, a drug withdrawal headache. That means if you give them, say, 10 tablets or 12 tablets in a month, they slowly there is chance of not there with the Remigipan. And the second thing is that when you take this, suppose even now I'm talking with you, I have an attack of migraine, you will not even know that I took the tablet because it is an orally dispersible tablet. There are very few tablets, as pharmacists, that they are orally dispensable. So you don't need water or something, you just put it under your tongue and it disperses. So it's a great advantage because if you're on a table, you don't need to tell anybody and just put this tablet and it's orally dispensable.
The
So
other
these
thing,
are the things
yeah,
I know about Remdesivir. Yes,
yeah. The other
Mona.
So,
thing,
so
yes,
you are favoring Dr. Nayak the Rimegipan oral form of the medication, right? So you are favoring the oral administration of this medication. That's what you are saying, right?
yes.
Yeah, that's because in a certain class of patients, those who have, it goes for both acute and chronic, but in the acute, those who have failed the triptans, and triptans has got all these problems, and also orally dispersible, and this is also for chronic. So if somebody has these features, I think it's better to give the oral Remdesivir.
So
It was also pharmacy people. You people are, always cost effectiveness. The price of the Remdesivir has gone down since it was with another company, and now it's taken over, I think, by Pfizer. And they have brought down the price just 1.5 months back. So it is now more affordable for the insurance company. I think
yeah,
many of
Yeah.
the people may not know this because when they were taking before 2 months, it was
and
more on the
actually,
expensive
doctor,
side. Yes.
and actually, doctor, in my opinion, so this challenge migraine trial compared actually galcanezumab to Rimegipan, and the primary one
Yeah,
endpoint
that
was
one,
to
yes.
show superiority. Yeah, remember, Dr. Muna, probably you are not aware of
Yes.
the acronym.
I forgot
So
the
this
name.
study
Yeah.
that
So,
oh, yeah, to show superiority of this was the primary endpoint, to show superiority of galcanezumab over Rimegipan in episodic migraine. However, the study failed to meet its primary endpoint, and galcanezumab was not superior to Rimegipan in episodic migraine, and that's, I guess, will change our practice, right, Dr. Muna? What do you think?
yes, because there was a feeling that galcanezumab is the strongest of all, and this study actually proved it wrong because the GPANs were equal to it was not superior. The galcanezumab was not superior, though it was sponsored by the company,
Now,
but they didn't
it
reach
is-
the endpoint. The other thing I wanted to mention about Rimegepant is that, of course, acute pain medications, we are always worried about medication overuse headache. This doesn't happen with the GPAN. So when we are giving it as preventive medication as well, there's no indication of an overuse headache.
So Maya, I just now, when you told me, we
Yeah.
remembered. It was not found to be superior, nor also they
Yes.
use another word, not inferior. So that,
Yeah,
in other words, you are telling that this
yeah,
medicine is as good. Yeah,
yeah.
that
And the
was a
doctor,
good
we have,
trial, actually.
yeah, and yeah, it was a very good trial because it's the first trial that compared head-to-head
Head to head.
CGRP molecules. So before this trial, we didn't have head-to-head comparison, and we rarely in neurology and in medicine in general we have head-to-head comparison. So that's what the advantage of the study. There is a question about vestibular migraine, which can occur during pregnancy. Does it disappear after delivery?
It can, but postpartum period, the migraines can actually become worse as well. When you have hormone changes coming in, and plus you have sleep deprivation, so these things do, make the migraines worse. So most of the time, it might stay.
There are few questions. Maya,
Yeah,
do you want me to go through? 40 to 60%
yeah,
of the migraine patient develop prodromal phase, minor changes that occur a day or two before the attack. How can I take advantage of this period regarding severity of the attacks or treatment? Basically, he's asking you whether you want to give treatment during the prodromal phase, Mona, of the migraine.
I think we can, yes, before the headache phase starts, because even that is very, disturbing. So you break the cycle before it actually starts into a vicious cycle, because treating migraine is, you have to treat it as early as possible. And if the prodrome is like 2 days before, these patients actually qualify for preventive medication. So you actually start preventing these before, rather than treating it, each time.
Okay, there is another one about dosage. If someone using rimegepant as preventive on alternate days needed for breakthrough pain, it is possible that a patient may use every day. Would this be an issue? Any concern about using daily? So what is the maximum dose of rimegepant per month? We have a number for that.
Yeah, so
Actually.
you can
Mona,
take
would you
only
like
18. Yeah.
to
So you can take
answer
only
that?
18. Yeah.
18 tabs. So
Yeah.
we give 15 as an alternate day, and 3 extra tablets are given to you in case in between those attacks you get acute attacks. So those attacks can be treated by giving these 3 tablets. But the prescription doesn't tell not to give more than 18 tablets in a month. So
Yeah,
whether you
because
have
that has
acute
not been
or you
studied
have
yet.
chronic migraine. Yeah, so FDA approves it only for 18 tablets in a month. Yeah. So I think, Maya, we have come, there is no more questions
yeah,
actually.
yeah. So thank you, Dr.
I
Nayak.
think,
So actually,
yeah, I want to again thank before I end the Pfizer group for and the Association of Migraine Disorders for giving us this opportunity. I also want to include Mona. She's my teammate many times. So I want to thank all the speakers and you, Maya, for helping with all the arrangements and working from behind. Should I say that? And thank you very much. It's been very interesting, and it has been a great pleasure for me to have chaired this talk today. Thank you.
thank you, Dr. Nayak. It's always our pleasure to have you. Thank you for moderating this session perfectly. And thank you, Dr. Muna, for always an amazing lecture. So thank you for accepting our invitation and for being with us tonight. And looking forward to see you and Dr. Nayak in our future events. Also, allow me to thank Andrea for joining us all the way from the United States and sharing an excellent presentation about management of migraine in pregnancy. Also, I would like to echo Dr. Nayak and thank again Pfizer, our sponsor for tonight, and for all these migraine series, as well as our partner and collaborator, the Association of Migraine Disorder. Thank you for all the effort. Let me again wish a happy World Pharmacist Day for all our colleague pharmacists who are attending the webinar with us tonight. Remember, a pharmacist is the most accessible healthcare professional. So take advice from a pharmacist, whether you have migraine or you have not, as they will guide you well, especially those pharmacists who are attending our IVPN NeuroPsychiatry educational activity and are being updated, receiving the most update about migraine and other neurological disease from expert speakers like you. At the end of the webinar, I would like to thank all our attendees for staying with us tonight. They are numerous today, as every migraine masterclass. And also, I would like to remind them that they will receive their certificate of attendance by email within 1 week of today. Also, if you missed any part of this webinar and you would like to revisit the lecture, you can visit our IVPN NeuroPsychiatry library on our website, where we post the recordings of all this webinar and all the previous webinar and all other educational activities. Our library is currently be accessible free of charge. So visit our library if you missed any part or you'd like to revisit the lecture. Also, don't forget to keep your eyes on our social media platform. Follow our LinkedIn page where we post all our activity. See you in October. We have more activities about migraine and other neurological disorder. Until I meet you again, stay safe and have a good night, everybody.
Thank you.
Shukran,
Thank
Maya. Shukran.
you. Thank you.
Atik
Thank you.
Shukran. Okay, Mona. Bye.